Okay, in the conceptual base of urology course, and today we will be discussing azoospermia. The format is that Dr. Wajahat and Dr. Farhan are going to talk about azoospermia, and then we're going to have a short MCQ poll kind of a thing, in which all participants can poll their opinion, and then we will discuss the correct answer and why it is the correct answer. So I think, Wajahat, if you're ready, we can start off.
Sure. Yes, thank you, Dr. Hamad. So we would be talking about azoospermia today. I have found that this is one thing which we routinely see in our clinics, but many residents especially are confused about the management aspect of it. Usually what the presentation which we see, and we would get some of the MCQs similar to that a young man, otherwise normal, having regular intercourse and presents with history of infertility, and the examination and past history is essentially unremarkable. And most of this time, the genital examination in this patient is also normal. And they usually come up with a report like this, which shows azoospermia. So our target today would be how to approach such a patient. So it's a three-step approach. First would be to establish that there is azoospermia, establish the type of azoospermia, and identify the underlying cause. Previously and still today, some people do not value too much about the underlying cause because most of these patients are destined toward assisted reproductive techniques, but there is increasing emphasis on identifying the potential underlying cause, and we would talk about it. Okay, so step one would be to establish that there is azoospermia. So the question should be, is there any differential to that problem? Because a patient walks in your clinic and have a semen analysis report showing azoospermia. So there is a concept of repeating at least one semen analysis, and this holds true for all patients presenting with infertility because of natural variability in the semen parameters, which usually happens. And this is a small series, but what they did that they repeated semen analysis with some interval for different patients. And as you can see in patient 1 and 3, the counts may even become negligible at times. For a normal person, this can happen over a period of a year. So that's why if you have an azoospermia, always do cross-check it. And the way to cross-check it would be to repeat it at least with a gap of 1 month. And at the same time, while you are asking the patient to repeat the semen analysis, one should consider removing the potential reason which may have led to those. Many a times, especially in our society, the reason could be some Hakim medication or testosterone injection, and you need to specifically ask about that when you are taking history. Because many patients do not consider that as so-called medication. If you ask them what are the medications you are taking, they would skip those. And there is a lot of data available, especially in COVID era, that the COVID and other viral infection as well, they do cause temporarily some oligospermia, if not essentially azoospermia. Okay. Another thing is rule out low volume ejaculate or an ejaculation. This is a different problem. A low volume ejaculate or no ejaculation in terms of retrograde ejaculation is a different problem and usually is not considered as azoospermia. So a history regarding whether there is an absolute an ejaculation or retrograde ejaculation, usually patients are able to tell, or they would come that they are unable to give us semen analysis. Or sometimes there would be a clear-cut history of some surgery like TURP, and recently I saw a couple of patients who had anal stenosis in childhood and imperforate anus, and they had surgery of imperforate anus in childhood. Or one person who had a surgery of this extrophy bladder. These are those surgeries which are definitely related with retrograde ejaculations. So they are clearly visible, usually based upon history, or you can further rule out by taking a post ejaculate urine sample for the presence of sperms. Second thing, in some of these patients, the problem is ejaculatory duct obstruction. Although this is technically considered as azoospermia and one of the cause of so-called obstructive azoospermia, but this is taken as separately. So if you consider the normal anatomy, and most of you know that the seminal fluid mostly comes from seminal vesicles, and only 5% of it from its testes. So if you have an obstruction at this level around the prostatic area by ejaculatory duct cyst, you would have a low volume ejaculate. And compare it with, and this is also the source of fructose and alkaline pH. So whenever you have a low volume ejaculate, consider these two factors, because low volume ejaculate is also possible with pituitary causes and in some cases of testicular obstruction. So only consider an ejaculatory duct obstruction is much more likely if you have a negative fructose as well as alkaline pH. But also note that sometimes the obstruction is only unilateral or partial. So it is perfectly possible to have a fructose positive patients, or sometimes they give as a faintly positive fructose, because this is a qualitative and not a quantitative test usually. So absence of fructose is not an essential marker for seminal seminal vesicle obstruction. But if you have all these factors, a low pH, a low volume ejaculate, and a fructose which is plus minus, then definitely consider ejaculatory duct obstruction. But most of the time, the obstruction is somewhere here. So once you have established azoospermia and you have established that this is not a low volume ejaculate, then the differentials are essentially whether it's a pre-testicular, testicular, or a post-testicular cause. Some people like to call it as hypogonadotropic or hypergonadotropic, but that terminology is usually much more confusing. So to me, this sounds quite much more clear, just like we classify jaundice. And if you see, for the first two causes, whether this is a pre-testicular or a testicular failure, the volume of the testes would be abnormal and the FSH would be abnormal. And so if you have these two things, then definitely this is a case of non-obstructive azoospermia, and you can further differentiate between the two based upon whether the FSH is low or high. A low FSH would definitely mean a cause higher up in the brain, whereas a high FSH would mean that there is no feedback from the testes and the problem is testicular failure. But the things are not that clear when you have a normal volume testes and a normal FSH. Usually, people would consider that if you have these two things, then the diagnosis is definitely obstruction, but this is not the case. Consider this algorithm from Canadian Urology guidelines, and that shows that if you have a low FSH, which is rarely the condition, only 2% of the patient with azoospermia, then of course the cause is pre-testicular, that is higher up in the brain. And if you have a high FSH, which is roughly 30-40% of the patient, then the problem is testicular failure, problem solved. But the situation is not clear. Reason being that there is a spectrum of FSH across all possible histologies. Consider this, the problem of maturation arrest, which is shown here as a triangle. So it is possible to have a maturation arrest with an FSH value as low as 5 or even lower. So if you really have to find a cutoff of what is a normal FSH, although most of the lab it is 12, but if you are considering the diagnosis of obstructive azoospermia, those patients with an FSH of more than 5, there may be a potential non-obstructive cause. I would further try to clarify it. The FSH is directly proportional to number of germ cells. And if you talk in terms of histopathology, the maturation problem is not picked up by this FSH. So if you have a maturation arrest, the number of spermatids and spermatocytes would be normal, but there would be no mature sperms. So there is no marker of maturation of the spermatozoa. So these, an FSH value and a normal testicular volume cannot differentiate between these two problems. That is, on the left side, you have a normal spermatogenesis with the normal spermatozoa seen. On the right side, you have what is known as maturation arrest, that you have spermatids, but no fully formed spermatozoas. So this is the problem. That's why when you have a normal FSH and a normal volume testes, there is a potential that you may have a maturation arrest. One classic example of this is what is known as Cottagner syndrome, which you have, where you have this dining arm of the sperms, as well as in the sinuses and bronchi, they are affected, and there is no sperm movement. So you would have a normal volume FSH, a normal testes, but the sperm would not be able to travel up the genital tract. Okay. So once you have established azoospermia and you have given a consideration in terms of if you have a whether you have an obstructive or non-obstructive, then do give some consideration to potential identifiable cause. So if for a pre-testicular cause, it is usually quite simple, that, and the way to work that up is to do a prolactin and MRI of pituitary gland. But do be aware that all these conditions would not be readily visible on even on MRI pituitary. Say, for example, a Coleman syndrome. Sometimes there would be an empty sella, but sometimes there would be no gross abnormality in the hypothalamus. So a pre-testicular failure, potential underlying cause, you do work up with a prolactin level, which is the most common pituitary tumor, and by getting an MRI pituitary, but all of these causes would not be necessarily visible on those. For a testicular failure, currently it is recommended that all patients with azoospermia should have genetic testing and should have at least a karyotyping and AZF microdeletions, because if you find any of those, irrespective of testicular size and FSH levels, the problem is a testicular failure. And sometimes you have an obvious history of undescended testes or chemoradiation, and you would see that there is a definite testicular cause in the history itself. Similarly, for post-testicular failure, sometimes there is a clear-cut history, but most of the time there would be no acquired history of an acquired blockage like hernia repair, which is, to be honest, much less common. And the congenital causes of obstruction are much more common. One of them, especially cystic fibrosis, is sometimes can be picked up on a clinical examination by looking carefully for the absence of vas deferences. Ejaculatory obstruction, we have talked about that this can be postulated based upon semen analysis, and additionally, sometimes you may feel a cyst either on a DRE or a transrectal ultrasound. But the ultimate way of looking at the obstruction would be MRI pituitary. A few words about the pre-testicular failure, that is a low FSH situation. So the way to work up, as I said, there would be prolactin and MRI pituitary, but essentially is a neuroendocrine disorder, and most of the urologists would not feel comfortable in treating those patients. If you have a prolactinoma, it would be preferable to refer them to an endocrinologist to put them on medications. But for those patients who have a pituitary failure like Coleman syndrome, and congenitally they do not have an FSH production from the hypothalamus, some of the urologists, or like in Coleman syndrome, where there is no underlying lesion in the brain, would put them on gonadotropins. There is a variability of the dosage, but because it's quite tricky and variable, so usually dosage would be HCG injections 2,500 units twice weekly. And if it fails to produce sperms in 3 months, you would have to add HMG. I would not go into details because it's preferred for these patients to be taken care of by endocrinologists, especially a reproductive endocrinologist. Regarding the post-testicular, the so-called obstructive azoospermia, for most of these patients, the obstruction is at testicular level, and really the most common site of obstruction is vasoepididymal junction. And sometimes the obstruction is at the level of ready testes. And very rarely this can be picked up by a good sonologist by looking at the mediastinum of testes on an ultrasound. If there is a real obstruction, long and standing obstruction, very rarely it is visible. Such a patient would be a good candidate for reconstructive surgery. Sometimes you may see a dilated epididymis either on examination or an ultrasound. Again, this is an indirect sign of obstruction. Surgery and congenital bilateral of vas deferens is something which you can ascertain based upon history and examination. Regarding the absence of vas deferens, sometimes it's difficult to be sure whether there is a definite absence of vas, and it has happened with people that the patient is taken for reconstructive surgery and peroperatively there was no vas. So this may at times happen because when the vas is absent, sometimes you can feel just a cord-like structure there. An MRI of the testes may potentially see all these things, but is not routinely recommended. Talked about transrectal ultrasound and a dilated seminical. Usually the cutoff is more than 1.5 centimeter, but there do exist borderline cases. And sometimes you feel that you are defect, but this is usually visible, ascertainable on history. Regarding the sperm retrieval technique, Dr. Farhan would basically tell you about the basics of sperm retrieval. Farhan, over to you.
Assalamu alaikum. Thank you, Dr. Hamad, for the opportunity, and Dr. Bajaj. It was a very good presentation and it was really enlightening. I would like to share some knowledge about the techniques of testicular biopsy and the types. So it was very well established how to reach a patient who comes with azoospermia and what we can do further. So basically, there are different types of azoospermia, and the classification is like intratesticular obstruction, which occurs in 15% of cases, and usually they are acquired post-inflammatory or traumatic. The other causes are epididymal obstruction, which is the most common type. It occurs in 30 to 67%. And they are acquired secondary to acute or chronic infections of epididymis, gonococcal and chlamydial infections. The other causes are trauma or surgical intervention. You can also find obstruction at the level of vas deferens, which is most common cause of acquired obstruction, which is not very common in our region, but vasectomies and which are done in other part of the world, where they have elective vasectomies and all. So they can have these obstruction at the level of vas. And we see the obstruction at the level of vas after post hernia surgeries, which is commonly seen in these male infertility clinics. There are obstruction at the level of ejaculatory duct obstruction, which is very less, which is about 1 to 5% of the cases. And usually it is because of the Mullerian duct cyst or urogenital sinus or ejaculatory duct cyst. And there can be obstruction at the level of, because of these, they can have seminal vesicle dilatation, which is...
Farhan, sorry to interrupt you. Can you keep your microphone a little closer?
Sir, is it okay now?
Yeah, this is much better. Thank you.
Okay, thank you, sir. If you find a person who has a seminal vesicle AP diameter on ultrasound more than 15 millimeter and ejaculatory duct diameter more than 2.3 mm in width, are usually dilated, and then that can be because of central obstruction at the level of ejaculatory duct opening. And the other causes can be functional obstruction, which can be because of any neurogenic illness or after spinal injuries or drug induced that occurs with the with some of the alpha blockers or other urological medications. So diagnostic evaluation is clinical history and examination, which has the most vital role. So obstructive azoospermia and concomitant partial testicular failure, you can have enlarged and dilated epididymis on examination. You can also palpate nodules in the epididymis or vas deferens. You can have absence or the partial atresia of the vas deferens. You can differentiate on the clinical examination as well. And the other tests that we run in these cases are semen analysis, hormonal levels like FSH, and there are some advanced tests, genetic testing, which are CFTR testing or Y chromosome microdeletion test. And ultimately, we do the testicular biopsy to rule out the other cause. So the basic thing that I have to discuss is the disease management, how we can advance with a person who comes with azoospermia. So basically, the only treatment that we have offer these patients is IVF or in vitro fertilization or assisted reproductive techniques. So how to retrieve the sperms from a person who have azoospermia? So in obstructive azoospermia, you can always find sperms at the level of epididymis, or so we can also do this. And if a person comes with non-obstructive azoospermia, then the sperms can only be found at the level of testes or the seminiferous tubules. So basically we do these procedures in like testicular biopsy, like micro TZ or percutaneous epidermal sperm aspiration or microscopic epidermal sperm aspiration in the patient with obstructive azoospermia. And for non-obstructive, we do the testicular sperm extraction or micro TZ. So there are a pictorial presentation in which you can see that the epidermis is present at the level of the head, and you can easily palpate it and you are examining a patient in a relaxed position. When you're performing a testicular biopsy, you can also do it in local anesthesia. I do this in a center. I practice this in a local anesthesia, and the patients are very comfortable most of the time. So I inject xylocaine 1% diluted injection at the level of the base of the scrotum on the cord on both sides, and I give 0.5 to 1 cc of this same xylocaine 1% intratesticular. It gives you a very good local anesthetic for like 10 to 15 minutes, and you can easily perform the percutaneous or the open testicular biopsies. So this is a pictorial presentation. You can, when you palpate the epidermis, you can hold it between the two fingers, and then you can easily approach the epidermis with the help of a 23 or 24 gauge needle. Some people use this butterfly needle, but for this you need another person who will assist you to hold the syringe for you. So I take a 3 cc syringe with a very small needle, 23 gauge needle, and by this I can do this with one. I don't need another assistant to hold the tissue for me. So the other option is testicular sperm extraction, which is an open technique in which what we do is make a small incision at the level of the testicular skin, usually at the midline. And when you open the skin, you find the tunica vaginalis. And you open the tunica vaginalis, you will find the most white tissue, the testicular tunica albuginea. And I usually what I do is make a stay suture with the Vicryl 40 or 30. I hold it on a artery clip, and then I make a small incision like you can see this on the picture. And you make a small chunk from the seminiferous tubules. Usually when you make a small cut in the tunica albuginea, these seminiferous tubules bulge out without any effort. So you just you just take a scissor and just trim it out and give it to the laboratory for further analysis. And you close it with the same holding suture that you have taken with the Vicryl 30 or 40, and these running sutures are taken. So this was the testicular aspiration. The other option is micro TZ. This is not a procedure that is given upfront. Usually, if the testicular biopsy is negative, then you can decide for micro TZ, which is a very prolonged procedure, and you have to further run a test for genetic testing like micro Y chromosome micro deletion test. And if it comes negative, then you can offer a micro TZ. Otherwise, it is useless to go for this test, because it is a bit more expensive and the results are usually same. So what we do in this micro TZ, we cut open the whole testicle and jail book open testes, and then we look at these small seminiferous tubules with the help of microscopes, and wherever we find some dilated microtubules or seminiferous tubules with the help of microscope that you can see in the third picture, you can always pick it up with the surgical forceps, and you can trim it with the scissors and give it to the lab for centrifuge, and then after centrifuge you can find some sperms in it. So once the sperms are taken out, you can always plan for the next procedure, which is IVF or ICSI. If the sperms are positive, you can always go for cryofreeze. Cryofreezing is a good option if the sperms are of good health, like grade 1 or grade 2 of motility. You can always freeze it for future IVF plans. So there are a few guideline recommendation which is given in the EAU 2020 22, and which says that if you are doing a microsurgical vasovasostomy or epididymovasovasostomy, it is advised to do it in a couple where the female partner has the good ovarian reserve. Otherwise it is useless to go for this extensive procedure. So use of sperm retrieval techniques such as microsurgical sperm aspiration or testicular sperm aspiration or percutaneous techniques to retrieve sperms, either as an adjunct or a reconstructive surgery. So if the condition is not amenable to surgical repair, or when the ovarian reserve of the partner is limited, so patient preference is not to undertake a surgical reconstruction and just go for the IVF or ICSI once the sperms are found. So these are the latest recommendations that I found. So next we follow is the assisted reproductive techniques. So this was a brief about the testicular biopsies and sperm retrieval. I would like sir to comment on it, and thank you so much.
Thank you very much, Farhan and Wajahat. I think these are wonderful presentation. You've talked about basic concepts, and andrology is something that we are forced into practicing as urologists. And unfortunately, the training is not appropriate. And during our training times, the exposure to andrology is very limited. So I think I'm really grateful to both of you, and for a very nice and very educating presentations. There are a few questions that maybe I think we should address now before we go on to the poll. So one of the question is, yes, Vijat.
If you allow me, I would address this question because they are very interesting.
Yeah.
If a patient has small testes and adult azoospermia, yes, this is the classic case of possible Klinefelter syndrome. Small testes, azoospermia, yes, this is the classic indication for karyotyping. Currently, for all patients with the azoospermia, karyotyping should be considered, although the Klinefelters would be picked up here. Low volume testes, high FSH, and azoospermia, this is the classic picture. Secondly, if you have a maturation stress arrest and testicular volume will be normal, yes. And the third question is that where you have all the things normal, instead you have obstructive azoospermia. So these questions are overlapping. That's what I tried to cover, that if you have a normal FSH, which is a marker of the number of spermatic cells, and it has nothing to do with the maturation failure. So number of spermatogonia are normal, the testis volume would be normal, and FSH would be normal. And if they are not maturing, or if there is an absence of this dynein arm or CDRE defect, they would unable to move up the genital tract. So that's why it is perfectly possible to have a normal FSH, normal volume testes, and still non-obstructive azoospermia. And way to differentiate between the two in the classic old days was a good old-fashioned testicular biopsy, in which the histopathologist should determine whether he was able to see mature spermatozoa or not. This so-called score, which we usually use, is sort of not useful in this regard. Or what you can do is to perform a PISA or a TISA, and if you can find mature sperms, the diagnosis of obstructive azoospermia is confirmed.
I think there's a very practical question about this biopsy, which is becoming more and more obsolete. And this question from Mohammad Ilyas about that doing a biopsy in centers where you do not have the facility to bank sperm or use them fresh for ICSI, is it justified in the modern day? Farhan, you want to address this?
Yes, sir. I would like to say something because we see many institutes, very small hospitals. They try to do these testicular biopsies in their own setups, but they unfortunately they don't have the facility for cryo-freeze or for further IVF procedures. So all these efforts from the patient end, for the financials and the doctor's effort, these are all lost in vain. So I would always say this in different forums and everywhere, that if you find a patient, refer it to a center where these IVF procedure are practiced. The biopsy is done at there. The if the cryo-freeze is available, it is done, and the procedure is done in the same institute without any other problems. So it is always indicated to send these patients to the infertility centers rather than performing these tests in periphery hospitals.
Thank you, Farhan. Vajat, is it a practical problem of development of anti-sperm antibodies following a testicular biopsy?
Usually not. This is more of a theoretical thing. And even after the testicular biopsy, the real concern is that there is testicular scarring and sometimes even loss of testes. And if a patient is a candidate for a micro TZ, then people would prefer not to use the testes from which the biopsy is taken. That biopsy report is actually useful because you can further, based upon that biopsy report, you would know whether you would be able to retrieve sperms or not. But the problem of anti-sperm antibodies, especially in the era of XE, is sort of irrelevant, because when you retrieve the sperms, you would be using them for ICSI. So even if you have anti-sperm antibodies, that are irrelevant.
Mute, sir. Dr. Ahmad, you are mute.
Right. Am I audible now?
Yes, sir.
Okay, sorry. So let's move on to the poll, and let's move on to the first question. And all of you have a right to vote, and you can vote, and kindly please vote within 1 minute of the question displayed. So please proceed. This is the first question. Okay, so Only 50% have voted so far. Please do vote. Okay, let's end poll now. And let's look at the results. So, Bajad, about majority have voted in favor of microsurgical testis sperm extraction with cryopreservation. And some of them have voted for bilateral orchidopexy as well. So any comments?
Yes, this is an interesting situation, and this is one condition where bilateral orchidopexy should be considered. There is very limited data on this, but there is one good series from University College London. They showed if the testes are at the deep inguinal ring, it is worth doing an orchidopexy, because once you do an orchidopexy, the micro TZ sperm retrieval would be much higher. But if the testes are higher up in the pelvis, deeper than the deep inguinal ring, there is little point in orchidopexy, and no matter what, you would be unable to retrieve sperms. For this patient, do an orchidopexy, and later he would need a micro.
Great. So the correct answer is bilateral orchidopexy. And I think the explanation is well provided. So let's move on to the next question. Sharif, can you upload the next question, please? Thank you. Okay, you have 15 seconds to vote now. And I am happy that majority of the participants are voting. Okay, we can end poll now. Well, Farhan, you did talk about the CFTR gene sequence and the necessity in certain situation. And any comments on the answers by the participants? Majority have voted in favor of renal ultrasound. Some have voted in favor of testicular biopsy and a transrectal ultrasound.
Yes, sir. So when we find a CFTR gene sequencing assay, so we always have seen that there are absent kidneys on ipsilateral side, mostly when these patients present with these gene sequencing. So the renal ultrasound is one of the reasons, but in a patient who comes with the infertility point of view, so the question arises that what we can do further. So the next option would be to go for IVF, and it starts with the epididymal sperm aspiration, which is percutaneous sperm aspiration, which is easily done in a local technique, and we followed by artificial techniques to go for IVF.
So, I mean, if you focus on the question again, this is the first and the second step. The first step was gene sequencing for the partner, so that the family can be counseled about possibility of cystic fibrosis, because it's an autosomal recessive gene.
Yes.
So if it is present on both the partners, there is a significant likelihood of the child to have cystic fibrosis. So I think that's the reason why CFTR gene sequencing for partner is important. Once you have done that, the next step is to do an ultrasound to make sure that both the kidneys are there, because there is a high likelihood of an absent ipsilateral kidney, as Farhan explained. So the correct answer is renal ultrasound after you have done the gene sequencing for the patient and the partner. So cystic fibrosis, as you all know, is a quite a devastating condition. The CFTR gene is on chromosome 7, and the mutation results in development of a clinical condition called cystic fibrosis. Uh, it is, and the sequencing that can identify these people is CFTR regulator protein. And this is what it's all about. So it's important that if this facility is available, and Vijat, do we know that if it is being done in Karachi or anywhere else in Pakistan? Vijat?
No, sir, it is not done in Pakistan routinely. CFTR
Okay.
gene sequencing not done here.
All right. So let's move on to the next question, question number 3, and kindly share poll number 3, please. Okay, let's end the poll now. Now there was a point from somebody on absent kidney at 27 years. Well, if you're doing sequencing, finding cystic fibrosis, either it is both kidneys present or one absent. Obviously, that fetus would never have been born if bilateral absent kidney are there. So, okay, so let's move on to the next question. And Vijat, Prader's orchidometer is something that we have been taught as residents and trainees, and that's what we teach our resident and try. What about this testicular size and long axis on physical examination and its clinical value?
It's a reasonable surrogate just to make an assessment whether testes are normal volume. So 4 centimeter is definitely good volume. If you have a 3 centimeter or less than 3 centimeter long axis, that is definitely a sort of low volume. A 3, or some people would say 2.5 to 4 centimeter, that is a borderline. So 3 to 4 centimeter is roughly a borderline testes. So it is sort of a surrogate for testicular volume. Of course, the more ideal way is orchidometer, or currently we rely more on the ultrasound. So it's more of a how you measure it. So 4 centimeter is definitely normal. This is a classic case of what we were talking about of maturation arrest. So FSH considered normal values usually considered at 12, but for an obstructive azoospermia point of view, the cutoff should be somewhere near 6. So if you have any value above 6, think more of towards maturation arrest. So this case, the values given in the option B are quite suggestive of maturation arrest. FSH a bit higher and testes volume normal. So this is a classic case to me of or maturation arrest. Or of the other cases where the testosterone is low, think of a pituitary cause rather than a testicular cause. Testosterone is usually normal in a testicular cause or borderline low.
Thank you. Let's move on to the next question. Question number 4. Can we share the poll on question 4, please? Thank you, Sharif. So this is an interesting question, and I am sure our residents would remember some basic teaching about semen volume and its possible source and cause. So this just tests your that basic science knowledge. We have about 60% voted so far. I'll just give another 5 seconds for you to vote, and then we can discuss this question. So thank you. I think we should end poll now. Over 70% have voted. Farhan, this is important. This is a very low volume ejaculate in a person with azoospermia. So any comments? How would you approach this patient in a clinic?
Yes, sir. After after the history and examination of the genitals, if we in the patient who comes with a very low ejaculate volume, majority of them can have obstructive azoospermia. So on examination, we can find dilated epididymis or vas. For further testing, I would go for transrectal ultrasound to look for any midline cyst or ejaculatory duct obstruction, in which we can find dilated ejaculatory duct or seminal vesicles or a central cyst. So this looks more like obstructive azoospermia, and ultrasound evaluation is more appropriate at this point of time.
Okay,
So, but-
Vijat, what about the volume and relationship with the, so for example, an obstruction would result in what kind of volume?
So an obstruction only at the ejaculatory duct level would lead to a low volume testes. But if the obstruction is higher up, that is in the vas deferens or epididymal level, the volume would be absolutely normal, because the semen would be draining from the seminal vesicles and the prostate. 90% comes from there. For this question, as the transrectal ultrasound is not the option here, because traditionally what we used to do, that first rule out, if you have a low volume ejaculate, first rule out that there is something going back and then look for the cause. So get a post-ejaculatory urine analysis, even if the history is not suggestive, because that is something which is readily doable and easily doable. And it does have a sort of value, because those same sperms can be used for ICSI. So if you can find those, that would be great. So even if you don't have any suggestive history, it's worth doing it, because some people have some neurogenic cause of some malformation of the bladder neck itself, which may lead to this irrespective of any suggestive history.
So yeah, I mean, I have noticed that people without any neurological cause can also sometimes have retrograde ejaculation, particularly these days, where a lot of people also taking alpha blockers. That could be another cause, but generally, even without alpha blockers, people can have very low volume ejaculate due to. So you have to specifically write in a urinalysis that please look for sperm in the urine, because routine they would not report, right, Vijat?
Yes, and this would, yes, exactly, because you only have to look for post-spermatic sperm, and usually the technician at the IVF centers, they are good at doing that. And one thing is, this is a classic case of type 1 diabetic. They usually present with this scenario.
Great, thank you. Let's move on to the next question, question number 5. A bit lengthy question, but I think it's important that you read it carefully before start answering. Please vote now. Please read the question from my slides and not from the poll, because poll has a certain limitation in terms of number of words. So the question is available on my slide, and that's why I'm displaying the slide. Okay, I think we can stop poll now, or people are still keen on. Yes, thank you. So what we have here, Farhan, is that small testes, the testosterone is low, FSH is very low. So what this situation would be?
So there can be primary testicular failure, or there can be growth, this genetic disorder, which can be pegged on
Yeah.
further investigations. So yes, we can always go for Y chromosome microdeletion assay, which is not done upfront. But if a person comes with these very small testicles and malformed, so we can go for it.
But one thing is
Okay.
that the FSH is low in this case. So
Yes.
so first you need to rule out a pituitary or hypothalamic cause. So practically we would be doing a prolactin and MRI pituitary. So the equivalent of this in this scenario is a smell test, because it is basically testing for Kallman syndrome, because most of the time the prolactin as well as the pituitary MRI would be normal. Then the underlying cause is usually Kallman syndrome. This is a classic case of Kallman syndrome. Yes, Y chromosome microdeletion should be done in all patients who are subsequently undergoing for sperm extraction. But for all these patients, do give us thought to an underlying finding and underlying cause.
So that's absolutely right. And this is a situation in which you have micropenis, cryptorchidism, anosmia, and facial features like cleft lip and cleft palate. This is Kallman syndrome, and this is associated with anosmia. And the upset or the University of Pennsylvania smell identification test is a pretty straightforward test. It is done on this kit in which you scratch a covered area and report on what you smell. And there are 4 options, and this test will tell you if there is partial or complete anosmia, and which is diagnostic of Kallman syndrome. Question number 6, and perhaps the last question for tonight. So please read the question from my slide and not from the poll. It would be incomplete there. Okay, start voting now. I think we'll give another 5 seconds for you to complete vote, and then we'll discuss the question. Right, I think we can stop poll now. Thank you. Right, Vajat, we have a split between D and E. So TURED versus sperm extraction and cryopreservation. What is your take on this question?
No, if you are planning a TURED, this is about sort of 1 centimeter is not the 1.5 centimeter is definitely where you consider seminal vesicle obstruction. 1 to 1.5 centimeter is sort of borderline. And many of these patients do not have obstruction of the seminal vesicle itself. So if you're planning a TURED, at least get an MRI for confirmation. And also if you have some other parameters like a low pH and a low fructose, only then you do an MRI and then consider for it. This does not happen. This is not unusual. Many a times this happens that you consider an obstruction at the ejaculatory duct level and you go in and start rejecting the ejaculatory ducts, and even after that, nothing comes out. So in this patient, this is not a classic case of ejaculatory duct obstruction. I would go for TISA.
Farhan, do you agree with this?
Yes, I will agree with this because the dilatation of the seminal vesicles and this is nearly normal. So it doesn't seem like a central obstruction. So next option would be sperm aspiration that we can do at the level of epididymis, or we can be done with the testicular biopsy, the TZ. So that can give you a non-obstructive azoospermia can be a reason.
Thank you. Let's move on to the last question, and then we can conclude today's course. Question number 7. Sharif, if you can share the question number 7. Great. So kindly read from my slides. Okay, I think we can stop poll, or maybe just give another 5 seconds. Okay, I think we can stop poll now. So Wajahat and Farhan, there's a bit of a split here between testis biopsy, microsurgical testis sperm extraction or TZ, with some people voting for epididymovasovasostomy and oral clomiphene citrate. So can you explain why the correct answer is D?
So
So-
in general, testicular biopsy is not the solution to any of the infertility problems usually, especially when you have the option of TISA or TZ in it. For this case, intentionally, there are some borderline cases because most of the patients do lie in this category. So if you see the testis volume is not very good. 4 centimeter is something which would you call as a good volume. This is sort of a borderline testis. Secondly, FSH is towards the higher side. So although as surgeons, we are, and even the patient is more keen to tend towards an obstructive cause. But this is whenever you have a borderline case, tend towards a non-obstructive cause because you do not want to end up in a situation where you do an epididymovasostomy and you have nothing in there. Testis biopsy would be sort of useless. This is just you want to confirm that there are some sperms in it or not. So the way to go forward would be a testicular sperm extraction. And in lower volume testes, usually you would need microsurgical testis sperm extraction. So usually what you do, you plan under GA, not under local. Under GA, you aspirate first, give to your technician. If he can find the sperms, good. Otherwise, open the testes under the microscope and go for it.
So Farhan, you would do the same thing?
Sir, a slight difference I would make here because this microsurgical technique for sperm extraction in micro TZ is a very expensive test and it is not done in every center most of the time. So what we do is we do a simple TZ first, and if we find sperms in it, then that's it. We can go for IVF. If it is cryo feasible, then we do the cryo freeze. Usually not cryo feasible option is available in testicular biopsies, but if possible, we can do that. If the first TZ is negative for sperms, then we can go for a micro TZ after doing the after checking the micro deletion of Y chromosome gene. So we can go for microsurgical testis sperm extraction. Yes, this is the answer, but it should be done after TZ is negative.
Yeah, I totally agree with Farhan. So the answer is between the testis biopsy and micro TZ. So practically you would be doing a TZ first. The
Yes,
testis biopsy is sort of useless and micro TZ is the ultimate solution. So you do the TZ first. Yes, exactly. So if that would be in our option, we would have opted for that.
So TISA first and then TZ if that is not.
Yeah.
yes, so the
Get-
TZ, so the TZ first, and if it is negative, we do the Y chromosome, the micro deletion test. If it comes negative, then we further go for micro TZ.
Thank you very much. I think that's a wonderful course on azoospermia, and I'm sure our delegates must have enjoyed as much as I have, and I have learned a lot today. So I'm grateful to Wajahat and Farhan for very practical and very straightforward answers to these questions. I'm sure that residents and our trainees and other colleagues must have enjoyed today's session. So thank you very much and have a very good evening.
Thank you.
Khuda
Thank
Hafiz.
you. Allah Hafiz.